Okay, my name is Srihari Naidu, and my co-chair moderator here is Dr. Tim Henry. We have a great panel this afternoon. For the next hour and a half, we'll be talking about cardiogenic shock. I think you've heard about the topic. Kind of the hot topic in interventional cardiology right now, how to take care of the sickest patients that we have out here. We have a wonderful panel from Megha Prasad to Poonam Velagapudi, Pervez Miraj, and Babar Basir. And I don't know if we have other people joining us shortly. I think Manas Balakas may join us as well. So we have one talk we have a variety of talks, and one of them is not here today. So we have plenty of time to discuss the literature in this space, clinical care in this space, as well as some new publications that we'd like some feedback on, since we're going to open up with that later on. So we can get the first slides. So how to diagnose and risk stratify cardiogenic shock. I'm going to take you through the sky shock definition. But I'm going to start with a case so people understand how we're trying to use this. This is a 40-year-old gentleman from our institution, came in with VFib arrest, CPR, AED, found shockable rhythm. Patient was defibrillated and regained consciousness, so awake and alert. Was brought and defibrillated 3 more times. So this was sky stage A with an arrest that started and then became E transiently with an arrest, then became B. So kind of pre-shock at that point, or C, depending on the exam findings and perfusion. That's how we want to have these patients looked at when they first arrive onto the scene. Then you've got the examination findings. Heart rate's a little tachycardic, a little hypotensive, crackles diffusely, cool extremities. So now this is a sky stage C, right? So you have signs of hyperperfusion, but still the A modifier. In the hospital, patient taken to the cath lab, PA, and then VFib arrest again. So this is stage E in the cath lab with the arrest modifier again. EKG shows things that we're all familiar with. Ischemic changes, injury pattern. Now you get the hemodynamics, and you can fine-tune it. So you have a wedge of 19, mixed venous really low, 25%, cardiac output 2.2, and index 1.2. And so you're down to stage D. So this is somebody on pressors. We don't know if the lactate's normalizing yet, but certainly refractory shock at this point, but no longer extremis. So hopefully that gives you an idea how you can do this at every stage of the game. And I think it's very helpful to see what these patients are doing, the continuum of care, and how they go up and down, as we'll show you later on. And then finally, you get the lab findings. Lactate's now 16. So this is a pretty sick patient, but still just on some pressors or inotropes, and still stage DA. Echo shows EF 10%, biventricular failure now. And now you have this. You have stage DA, but now you know it's biventricular failure, acute shock, so it's not acute and chronic, and you have cardiopulmonary failure. So this begins to understand the risk modifiers that we'll talk about shortly. So we go from, I don't know what it is, but I don't like it, to it's stage DA with X, Y, and Z modifiers. And that's how we kind of want to see the field evolving. So what is cardiogenic shock? It's when the index or output is insufficient to meet the metabolic demands of the body, results in hyperperfusion, usually accompanied by hypotension and compensatory tachycardia. Lactate rises due to conversion to anaerobic metabolism, end organ injury, backwards as in the liver, and forward, backwards and forward in the kidneys, and forward in the brain. Lower threshold in acute versus chronic, and higher threshold in fit individuals, so young individuals, good myocardial oxygen extraction in their extremities, they can survive longer without developing cardiogenic shock. Can be due to multiple cardiac etiologies and phenotypes, and that's where I think the field has to go. And that can be sequentially or acutely. And then it's progressive, of course, if left unchecked, leading to this inflammatory response, vasodilatory aspects that require pressors, regardless of the stage of shock. So we came with this definition, myself, Tim Henry, and various others on the panel as well in 2019. The first sort of foray into this, we had the 5 stages here from A, B, C, D, or E that you're all very familiar with C being classic, and then we downgraded patients into pre-shock of B, and A, patients at risk, and then finally all the way up to D, refractory shock, and E, extremis shock. And you can see here we had the table. As I mentioned, the reason why I went through that case is that it's very clear that you come in with physical exam findings, then you can fine-tune it with biochemical markers, and finally fine-tune it with the hemodynamics to go up and down the scale based on the data that you have in front of you. We then validated all this through a variety of databases. This is the Mayo Clinic database showing about 30% of patients in an all-comer population is in C, D, and E. If you look at these patients, as you go up from A, B, C, D, and E, you have an increase in mortality both in the CCU and in the hospital stay. And these are separated by confidence intervals that show in a worsening of mortality as you go up. We also saw this in 30-day mortality using C as the index, line of unity. At every stage, going down to B and A and up to D and E, you have a significant difference. Everything is significant from each of these stages. So they were very good at discriminating. We then looked at 30 days and 1 year mortality and saw the same thing. Interestingly, no matter what stage you're in, B, C, D, or an E, your mortality is up if you came in cardiogenic shock. And so even if patients look pretty good when they first come in and they maybe just go to B, they still have an increased readmission and hospitalization and mortality rate at 1 year compared to if they did not have that. The other thing is that's a great equalizer in cardiac arrest. So you can see A is pretty usually these patients do quite well with a high survival rate, but if they have an arrest, A and B is about the same, 30% mortality. C and D become equalized when there's a cardiac arrest as well at about 50-50 flipping a coin. And this is why most of the cardiogenic shock data heretofore was showing about a 50% mortality. And finally, if you're in stage E with an arrest, you have a mortality rate of about 80%. And this leads us into understanding whether patients might be futile as well. This is data from Bobber's NCSI looking at Impella. These are the sickest of the patients. All of these patients were stage C, D, and E. This is some of the earlier data that we have that lactate is very important. If you can normalize your lactate, certainly within 24 hours, these patients tend to survive. And if you can't do it, something's going wrong. And this led us to looking at what happens to the SCAI shock stage, not only on admission, but in 24 hours. And it really highlights the point that if you can make differences in these patients using the SCAI definition and trying to downgrade their stage from E to D, D to C, C to B, or anyway jumping down, where they are at 24 hours makes a much better difference in terms of prognosis than where they are when they first come in. So we then updated this in just earlier this year, actually, late 2021, early 2022, in JSCAI and in JACC. And what we did is we realized that we need to modify it. In other words, the definition is very helpful in terms of severity of shock, but depending on the population you're studying, whether they're more urgent or emergent versus more elective coming in, these patients really have quite a bit difference in their mortality rates. Look at the red graph here, red bars here. Mortality can be as low as 40-45%, but as high as 80% or 85% in stage E. And all the mortalities are kind of all over the place. They are stratified in that for every given population, it goes up with each stage, but across the board, there's a lot of other things that are modifying this risk. And this led us to this three-axis model of other modifiers. And we've known this for some time because there's been lots of different risk scores to try to figure out how to figure out prognosis in these patients. So there's clearly more than just severity. Severity is on the top there, but we have all these other non-modifiable and modifiable risk factors on the lower right. And we have also this whole developing field of phenotypes and etiology. We do know that an AMI cardiogenic shock is different than acute on chronic heart failure cardiogenic shock. We know if the kidneys are involved, it's different. We know if the brain is involved, it's different. We'll come back to that, but what we ended up doing is refiguring this pyramid showing gradations of risk. So all the colors are now blended into each other, showing that you can have a sicker B and a less sick B, and a sick B can be worse than a less sick C, depending on the modifiers. And so we have to go through this and figure out how to use this in a given population of patients. We then updated the tables, and you can see this in the paper that A, B, C, D, and E are about the same. We kept the physical exam markers, the biochemical markers, and the hemodynamics. We then highlighted typical features and features that are sometimes included to make it a little bit more user-friendly at the bedside. You can see that for C and also for D and E. We then added this final figure, which tells us how to go up and down. And I think this is very helpful in that you take a situation where you have an acute cardiovascular event, then you may go up this from A to B to C, and then if you have an intervention there and it doesn't work, you go to D, and then you may go to E. You can jump all the way to E, so as in our patient in the beginning, all of a sudden the patient got sick and had to have multiple rounds of CPR. Well, that goes right away to E, but then you may stabilize with some support and go back down to C. So this shows you how you can go up and down, and that C is a very critical component. And this is where we start wondering what happens with devices. So if you have a device in place and you normalize perfusion, you stay at C. If you have pressors and you normalize perfusion, you stay in C until you can withdraw those. So hopefully that's very helpful. The last little part here I'm going to talk about is phenotyping. Dr. Kapoor has done a lot in this work. This is how do we look at the heart as a whole, RV failure, LV failure, or both. There's a hypoxemia. How much total support deficit is there? What are we missing? And this gets into the realm of, well, depending on the support deficit, what kind of support do you need? And we're going to talk about that later on, I'm sure, over the next hour or so. What kinds of devices do we have? What kinds of solutions do we have to make that gap disappear so that the patients can normalize their perfusion? And I think you guys are all familiar with this. Looking at cardiac power output is one of the key measures, looking at the totality of power output with some thresholds based on the shock trial. And then the first thing you do to try to phenotype RV versus LV is the quarterback working? Do you have enough in the RV side to support the LV side? And this literature has happened also for mechanical support devices in terms of biventricular failure and biventricular support. This is Dr. Kapoor's diagram of phenotyping. I think this is helpful for fellows and those in training and early career to understand how to use the combination of the physical exam findings, the shock severity scores, the PA catheter, and the echo to try to figure out what these patients need. And then at the bottom, what do you have available at your hospital? Not everybody has BiPella, not everybody has ECMO. What do you do well? And this is where the heart team comes into play. So I'm going to end with this last slide, which is that the risk modifiers are there, but we need more data. We need large numbers of different combinations of all three components at all different time points. So at 24 hours, if you have this kind of this kind of severity, this age population, and this kind of phenotype, what does that person do on time 1, 24 hours, 72 hours? What is the prognostication there? And this is becoming very complicated because you can have all these different permutations that will have different prognosis, but that's where we have to go. Thank you very much.
All right, Hari, thank you. That was outstanding. And I think clearly we know from SkyShock that it clearly helps. It can help predict outcomes. And the question is, how should we use it going forward? So we're going to start here. We're going to start Megan. Can you go first and then get the input from the panel on how you personally use the SkyShock classification, and how you stratify in your institution, and how you deal with cardiogenic shock?
Yeah, that's a great question. So first and foremost, like Dr. Naidu mentioned, I can't stress enough the importance of the heart team. And so the way our team works is we have members from a perfusionist, a surgeon, a heart failure specialist that specializes in shock, and the interventionalist. And together, the first thing we do is look at the SkyShock criteria and understand where they fall, because that helps us understand, like Dr. Naidu already talked about, what the risk is in terms of their overall mortality and what we can be doing to help modify that risk. Now, when you look specifically, once a patient is in extremis, those patients, if they're a candidate, are often, we put onto ECMO sort of in the D and E range pretty quickly, and have had good outcomes with that. The A and B is the area where I think we struggle a little bit more, because every one of these devices has a risk, and so we often find ourselves trying to decide between a balloon pump or an Impella, or can we ride them out on pressors and whatnot. And so I think the real answer is we need more data, but we modify sort of the 3-axis diagram that Dr. Naidu just showed. I think the risk plays in. So if you have a 90-year-old frail lady that's B, we may not put in the Impella on that patient, and we may try and modify that risk. But let me turn it over to Poonam and see what she has to say.
Yeah, I think that's kind of what we do as well. We have a shock team at our university, and it has heart failure, predominantly heart failure is leading that. But we have heart failure, interventional CT surgery, ICU team members, and whenever there's a patient with cardiogenic shock, whether it's interventional, structural, so everybody gets involved and to decide what would be the best support strategy. Not just support, but if there's a patient with valvular disease, does this patient need immediate MitraClip, for example, severe MR. So those kind of treatment decisions are made by the heart team, by the cardiogenic shock team. And we also have some protocols within, for example, in our ER, we get called always with the cardiac arrest patients to take them to the lab, and we were having a lot of mortality because you do a PCI, but they die of something else. So now we've created a score called a CAP score, and then we look at a lot of things like the lactate and a lot of other things that are important. And then when the score's less than certain number, we then take them to the lab, because then there is a chance that they would survive. Otherwise, we know that it's futile, and then we don't have to do this argument with the ED all the time. And the third thing is, in the lab, whenever there's a STEMI patient or somebody who is hypotensive, we always make sure to get those, an LVEDP or a right heart numbers before the patient leaves the lab, and put a SWAN in when they have the device. So those are, I just summed the things, how we do things, but I didn't summarize A, B, C, D, E, which Pervez will.
No, I think I think Hari, you really said it well in terms of the stages of sky shock. So I think from a practical perspective, we sort of bucket the patient initially. So the first bucket would be: is it an AMI shock or is it a non-AMI shock? I think that's very easy to figure out early on, quickly, without too much information. And if it's an AMI shock, I think we treat them like you would treat any STEMI patient. You bring them as fast as you can to the cath lab, do what you need to do, support them, right heart cath, hemodynamically support as necessary. You can stage them at that point, determine the sky shock stage, and then support them as you see fit, and obviously then perform the PCI if it's necessary. The complicated ones are the non-AMI shock patients. Those are the ones that are much more complicated, and those are the ones that need a little more legwork up front to understand what the next steps are, at least in our experience. We are a transplant center, as many of us sitting at this table are at, and I think that the determination as to whether or not they are a candidate for advanced therapies, I think, is a pertinent conversation that you have at the beginning of the presentation of the case. So, I like to bucket it into two different categories. AMI shock, I think, is a much easier bucket for us to initially go through. The non-AMI shock is much tougher.
Yeah, and we use the sky shock classification really to communicate with each other, because I think what it does is it's really a simple and easy tool to be able to kind of help make sure that when we're talking and describing a patient for transfer, for escalation, amongst different services, really comprehensively to get a quick, easy picture of where they are at the time of that decision making.
All right, so we're going to go on. Before we go to the next one, I want everybody in the room has to commit on this now. We're going to ask two things. How many are you at an institution that has a formal shock team that actually is works for, and the majority of cases go through it? How many? Raise your hands. All right. How many have a standardized shock treatment algorithm that is outlined for your institution that theoretically you use as best you can and try to stay with that? So if I'm looking at this, it was roughly, the shock team was maybe close to 50%, and a standardized algorithm was maybe about 20. Is that fair?
Yeah.
Okay. And now we're going to hear what the best protocol should be by Dr. Basir.
So I've start by saying thanks to the organizers for having me. It's really a great privilege to be here. CVI is such a nice and intimate meeting, and I think we're going to have a lot of great discussion. These are my disclosures. I'm also going to start off with a case, and what I would ask each of you individually is to help decide if this patient would have survived in your institution and what you would have been able to offer this patient, and whether you would have been able to offer certain therapies as quickly as you would have wanted to in this scenario. So this is a 63-year-old, has a family history of CAD, was cutting his grass, had an anterior STEMI, was hypotensive in the emergency room, or came to the cath lab lethargic, short of breath, ongoing chest pain, gets quickly intubated, worsening hypotension, is started on norepinephrine. He comes to the cath lab and he's clear-cut in STEMI and cardiogenic shock, so we know that the chances and likelihood of using hemodynamic support are going to be significantly high. We're going to make sure that we get meticulous access using ultrasound, fluoroscopy, micropuncture. We take a quick angiogram, confirm that the LAD is occluded, get a second access, and then start making some decisions. Unfortunately, he has a cardiac arrest. He gets an Impella CP put in very quickly. It was being prepped on the table anyway. He gets a guide catheter up, wire down the LAD, a little bit of ballooning, a proximal stent, has some no reflow down the LAD as well. He's hypotensive, increasing doses of vasopressors and inotropes, and the operator calls for an ECMO. It's available to him immediately in the cath lab. Perfusion is not needed in the cath lab because the nurses in the cath lab are trained to at least start the ECMO. He goes on to optimizing his revascularization, uses IVUS, vasodilatory medications, gets good TIMI-3 flow, puts a right heart cath in, and is now on Ecpella. This was emergently put in, so he gets bilateral access for reperfusion sheaths. Patient goes upstairs, one-to-one nursing care, advanced heart failure consult for urgent LVAD in case it was needed, palliative care consult routinely done to make sure family, providers, and patients are all on the same page with goals of care, and hemodynamic guided weaning of support. ECMO comes out on day 7, and Impella removed the following day to add a little bit more support before taking everything out. Discharged to rehab on day 11, started on goal-directed medical therapy, completes cardiac rehab, does 15 minutes on a modified Bruce 3 months after his MI. EF is improved to 50 to 55%. He's had 2 years of follow-up with no significant hospitalizations. So how many of us could have saved this patient, delivered care in an expedited fashion to be able to get a great clinical outcome for this patient? And that's what we have to ask ourselves individually, institutionally, and systemically, because this is the kind of outcomes that we can get with the technological advancements that are available to us today. And that's why I'm so passionate about the idea of creating shock protocols, shock teams, some form of systemic treatment strategy for the most complex patients that we're taking care of in our cath labs. The inherent reason for putting together a team and a protocol is to decrease the delay, because the delay in these patients is associated with mortality. And so whether you look at arrest, whether you look at shock and arrest, these patients need to be treated extremely quickly. The idea of putting them on vasopressors and inotropes, waiting till the morning to see how things are going, putting in an ineffective balloon pump in somebody who requires more cardiac output is insufficient for treating these patients in 2022. And the Innova group showed that for every 16-hour delay, for every shift of different clinicians and nurses that are available, there's an increased mortality of about 25%. Now, there are more nuances to creating a shock protocol than just treating patients quickly. Just as Pervez mentioned, you have to be able to delineate whether this is an acute or chronic presentation, because those chronic patients have compensatory physiological changes that are in place that allow them potentially to use a smaller device like a balloon pump early, or really needing complete hemodynamic support during later stages of shock. But the acute AMI patient has a larger cardiac output deficit early on, and so they do better with intermediate devices like an Impella CP to improve the cardiac output deficit, and rarely, less than 20% of the time, will need escalation to full hemodynamic support. When we're making these decisions and these nuances, it's important to also be objective. And so to have invasive hemodynamics, to be able not to just compare patient with patient, or type of patient, or one doctor versus another, or what one institution does with another, but to have actually quantifiable objective measures to help make the decision between univentricular, biventricular shock, and what we're actually capable of delivering for these patients. What I would encourage this group and everyone, though, is to stop talking about shock as balloon pump shock, Impella shock, and ECMO shock. There was a recent article that's going to be probably brought up a little bit later on, looking at claims-based data in the JAMA network this week that compared balloon pump to Impella. And the editorial of that article essentially suggested that Impella was ineffective and should not be used in cardiogenic shock. You can see that what we do at Henry Ford is we use all of the devices. We have balloon pump, ECMO, and tandem heart and Impella. And this is really the importance of having all of the tools to be able to treat these patients. And I give Cal a lot of credit for bringing ECMO to our lab, because it's really, really critical to have all of the tools to be able to deliver patients what they actually need. So if that patient example that I gave you was a patient that came to a rural community hospital, all of which have balloon pump and 95% of which have Impella, but less than 5% of current cath labs would have the ability to put the patient on ECMO. What would have been the outcome of that patient? he probably would have died. Now, is that the Impella's fault that he would have probably died if they tried to put in an Impella to save this patient in this high-risk scenario? Probably not. It is important to get to the idea whether that would have been effective or not, but really these claims-based data and the way that we're researching hemodynamic support is really problematic and does warrant further discussions. To really be able to optimize care, you have to have leadership, teamwork, and a lot of hard work with continuous quality improvement. It starts with local shock algorithms and teams. So at Henry Ford, we have 10 cardiac interventionalists, 10 heart failure folks. Each of them are on call. All of them have a lot of experience in shock. That automatically became our team 7 years ago. We did the same thing, or Alex Truesdale did the same thing at Inova. He had 40 interventionalists, and he was sending patients to the MICU with multiple different groups involved, with people who were fresh out of practice to people who had been practicing for 40 years. Well, he needed to narrow down that scale and have 6 people on call to make a shock team. All of us are going to practice in different environments, and all of us need different things, but the core principles are what's important for making a local shock protocol. So to conclude, the best shock protocol is the one that helps clinicians identify cardiogenic shock rapidly to deliver the most effective MCS device for that given patient, and it's based on what you can locally deliver for that patient. The nuances of choosing the best device are going to be further clarified in randomized control trials. ECLS shock, danger, and recover for, which are all eminently in the works. But further data is available, and until further data is available, the best practices implemented in the shock initiative are really what I consider to be the best protocol to be used in AMI cardiogenic shock. Thank you so much.
Byron. All right, that was absolutely outstanding talk. Go home and listen to that talk over again, and play it to your cardiology group, because it's fantastic. And it really reminds me, we're a few years into this now, but it's like when we started STEMI Systems of Care in 2000. People said you couldn't do it, and when you do it, you make a difference. Yeah. And the second thing about it is, when we have, the more places that we have that are organized and have shock teams and have shock protocols, the better we're going to do to actually be dedicated towards putting patients in clinical trials and answering questions that we still need to answer. Now, I have one question that I think is important, that we think, great presentation of the patient, except one question. What antiplatelet therapy did they get?
Exactly my comment as well. So we don't protocolize that, but the shock initiative actually looked at this really extensively, and so we've recommended Cangrelor and IsoShock, which is an upcoming trial, because these patients have a 30% risk of thrombectomy, of needing aspiration thrombectomy, and very high thrombus burden. And so we know very clearly that they're actually not getting good antiplatelet absorption early on. So I fully agree with you.
So that's going to come up not in this session, but also later, because I will say that we focus so much on right heart and MCS and even the pressors, that we've forgotten that getting a good PCI result is really critically important. Yeah. And the slow flow business, if you look at every single cardiogenic shock and cardiac arrest study, they have worse TIMI flow post than a standard STEMI, right? And part of that's probably because of it might be because they're sicker, but certainly a possible reason is because they have inadequate antiplatelet on board. So don't forget that part. No.
Yeah, I'll tag on to that, which is that in the quote-unquote old days, these patients are very sick and they'd get the oral agents, and then some of them will have stent thrombosis you may not even recognize. Mm-hmm. And that contributes to their evolving shock state. And so we need to, I think these new medications allow us to not worry about that and then allow some recovery. The question I have just listening to you is, we've been doing this for a long time now, trying to figure out how to get the best shock protocols for different hospitals. I think you made the good point that there is no best shock protocol. It's the shock protocol that works to get you the best outcomes at your institution. However, how do you know what the best outcomes could be at your institution? That's a challenge, because if you don't have ECMO, you will see your most dramatic saves as the best that could ever be done. So this brings up the issue of when you need to transfer patients, and I think it becomes very difficult for people to understand that they're not doing everything that the patient could get, but they're doing everything that they can do. And I think that's the hurdle we need to cross. It's not an ego thing, because I've worked at different hospitals, some that don't have ECMO before, now they do, but I can put ECMO in the cath lab, same thing, and we rapidly escalate. So I guess we're going to start the other way and come down. You know, what do you think about that concept of what are you missing in your institution, and how do we make people understand that they could be doing better either at their institution or by transferring the patient in a timely fashion?
Yeah, absolutely. I think that's a great point. I think that's actually probably apropos to, we'll plug our Sky Shock meeting, because that's pretty much what we're trying to aim at Sky Shock, so everyone come. But I think to answer the question, I'll answer in two ways. One, I'm part of a very large network, as everyone knows, and I have 26 hospitals. 26 hospitals do not have ECMO. Most of those hospitals don't even have a cath lab, right? So you have to recognize the shock first, and then recognize when you need to move the patient and where you need to move the patient. So the first recognition, ground zero, is know that someone's in shock. The second point is, where do you send them once you know they're in shock? I think this is where the stages of shock, I think, are very important as to where you transfer them, because not everybody can go to the transplant center. That would not be feasible or logistically possible. So you have to be able to recognize what shock stage they're in and where they would end up. Within a health system network that's built under one umbrella, it's easy to make that protocolized. And that's what we've done. We've protocolized that across the 26 hospitals. Doesn't always work perfectly, and that's why I love Tim's point, theoretically. Because it is theoretical, there's a lot of deviations to it, but patients are different, so you can't always, they don't always match up. But in non-system, I think it's very important to partner with your local institutions. And I know that, I think Barbara can speak to this better than anyone. You have to be able to work together even if you're not financially together in this. And I think that's the most important thing, is because you're really trying to take care of the patient. This is not about me, this is not about you, this is not about the hospital, this is not about the cath lab, who really cares? I'm not trying to tweet this out and show myself to be the best person in the world. If that patient doesn't survive, it doesn't matter who took care of them, it doesn't make a difference, right? So it's on us to make sure that we do right by our patients. If you do what you can do at your institution, recognize that your limitations are, you can't place ECMO, you can't monitor them in the ICU, maybe you can put an Impella in, but you really can't manage them after you do that. Whatever it may be, send them on to the next place so that they can actually take care of that patient, because then you'll look like the hero, because you did exactly what you should have done.
So yeah, at the University of Nebraska, we don't have a huge internal network, but we have a lot of referral hospitals, because we kind of get all the high-risk patients, patients who are not doing well in surgery or even like PCIs, all of them get transferred to us, and same thing with shock. So the one good thing is, they call us early on, even like when they're doing a STEMI case or something like that, and they call us and they say, hey, this is how the patient's doing, we're going to put in the device, do you want us to transfer out right now? So we get a lot of those calls, but we haven't formally made a network, because our cardiogenic shock teams was just started recently, a couple of months ago. So I think that's in the works, but that's really important to coordinate with your referring physicians about shock stages and when they need to send these patients out. I think the sooner they recognize it and send, the better. And I think a lot of it is in doing outreach and getting these people to listen to cases and all this stuff that you guys have presented.
Yeah, I think the case that you showed, every one of us and any interventionist would want to be able to deliver that, right? I think getting the word out there so that people can recognize what the limitations of their institution are. In our system at Columbia, so we have our main cath lab, but there's 2 cath labs that are affiliated with Columbia that have some limitations in what they can provide. But those conversations starting early is sort of how it works. And so, and many of us will go to those other hospitals every once in a while. And so there's enough of a relationship where those interventionists will call, or those interventionists have privileges at Columbia where they may transfer the patient down and then they may come later to do a future intervention or whatnot. So I think communication and sort of really feeling like everybody's on the same team taking care of this one patient helps.
Okay. One final question, just for you only, because you showed one graph where you mentioned we're using everything, and we use everything in our institution too, in different varieties. But I noticed the balloon pump arm went down and came back up. What did you learn there?
Yeah, I think what it was that the use of balloon pump in heart failure shock is really still something that's practical and applicable to everyday practice. So there's a lot of discussion with our European colleagues that balloon pump is dead. Well, balloon pump isn't dead to me. It's something that we commonly use in heart failure. I think it's an extremely important tool for the transfer process, because if you don't have good experience with large bore MCS, the last thing you want to do is stick large bore MCS in and then transfer the patient with the complication. I'd rather take the patient with the balloon pump and then escalate myself directly in the cath lab for that patient. So that's where we kind of gathered. Now, that specific numbers were what we put in our own institution. That's 400 devices a year. Plus, we get probably double that in terms of transfers of devices. So the whole institution is ground in hemodynamic support device management. And I think that's where we realize the utility and use of all of the different devices.
That's great. Thank you. So next we have Dr. Tim Henry is going to take us through the whole topic of cardiac arrest.
Yes, in 8 minutes. Yeah. So actually 2 things just as we're pulling the slides up. I think 2 other important parts about having a shock team protocol are having a coordinator that's in charge of that, so that you can actually, if what went well last night, what didn't go well, and have you basically, when there are challenges, and there will be challenges, have a way that someone's in charge of trying to fix that. And then number 2, having a registry so that you know your data and then can look at your data. And I think that's what Bauer's done really well, is they have great data, so then you can make adjustments to your algorithm. You know what's working well and what's not working well. So 2 other critical things. What I'm going to do now is really talk about cardiac arrest and what I think are some important contemporary issues. And it's important to know that if you look at cardiogenic shock, 50% have cardiac arrest. 50% don't. So this is an important thing. I'm going to show you that the interaction of cardiogenic shock and cardiac arrest is critically important. And I start this, I don't have any disclosures, but I'll say that sometimes it's personal. So on the left side, you wonder why I'm passionate about STEMI, is my grandfather, sitting next to JFK there on the right, and he died of an MI at 62, and he should have never have. He wouldn't today. And on the right is my father, who died of an out-of-hospital cardiac arrest. So the point is we can do better. So right now on out-of-hospital cardiac arrest, $300,000 to $400,000 a year, 100,000 patients a year. Difficult to get those numbers, which I'm going to show you. Previously, the median survival rate was about 8%. And again, depends on how you count it. And the reason why they die, the number 1 reason, is because of noxic brain injury. And that's a really important thing to remember about when you take into consideration cardiogenic shock cardiac arrest trials. And we'll talk about hypothermia. So this is the issue about cardiac arrest. If you talk about all cardiac arrest, or just people to make it to the hospital, or just people make it out of the hospital, you can go from 350,000 out of hospital arrest, 100,000 had CPR, 40,000 made it to the hospital, 20,000 discharged, 12,000 with no neurologic outcomes. So you get the picture. When you look at articles about cardiac arrest, it depends on who's looking at it and where. You have to understand what's the patient population. But what you saw before about 2010, consistently less than 10% survival. What you've seen since then, and 2 things happened: better CPR, hypothermia, and more aggressive PCI. And now in the randomized trials, and in arrest, there have been some good randomized trials that I'm going to show you. Typically, you have about a 50 to 60% survival. So there was an inflection point, and the question is, why has that happened? So number 1, this chain of survival, remember, with cardiac arrest, it really involves having AEDs, having community CPR, having getting patients to the hospital quick. It's a big process involved in that. It's not just what happens in your cath lab. And so if you look at communities, you know where the best place to have a cardiac arrest is? Actually a casino. And so there's things like that because you have AEDs and people that are trained to take care of you. So don't forget this first about early CPR and the chain of survival. So I'm going to focus on 3 things: out-of-hospital cardiac arrest, who should go to the cath lab. It's a really important issue. This is actually old guidelines that, in 2013, which are still not up to date, but class 1 indication for hypothermia, level of evidence B, and we're going to talk about that. And immediate angiography and PCI, when there is ST elevation, is a class 1 with a level of evidence of B. Now, why does that come? Because there's PATH studies, a bunch of them, and generally in PATH studies of out-of-hospital cardiac arrest, about 70–75% of patients have a thrombotic lesion. If you do angiographic studies, it depends on how you do it, but that number's been around 70%. And it occurs in both, more in ST elevation than non-ST elevation, but it occurs in both. So that led people to say, listen, acute coronary syndrome is an important part of this. And then there's a whole series of data that were observational that showed that better outcomes, on the left is STEMI, on the right is non-STEMI, better outcomes when you get PCI than if you don't get PCI. But this is impossibly confounded. And so it was important for us to go through and actually have data. But when you looked at, this is from PROCOT registry, and actually the patients that survived if you had a shockable rhythm, number 2, if you had successful PCI. But there's probably a reason about how you select those patients, and ST elevation was on the right side. And the other things were actually made you worse as you got older, high lactates, diabetes, and the time to arrest were all poor prognostic. So a few years ago, we actually put together an out-of-hospital arrest, a really nice paper in JACC, and in the red is ST elevation. I still think that if you have clear-cut ST elevation, that you should go to the cath lab. And on the right, in blue, is if you have non-ST elevation, no ST elevation, then actually you should take the time and think, and I'm going to show you data now that those patients do not need to go to the cath lab. But then in black, were characteristics that were, that you need to really consider should the patient go to the lab or not, because they're poor predictive outcomes, okay? And so, this is for people with return of spontaneous circulation. And I'm going to end with no return of spontaneous circulation. So what's really happened? So the Tomahawk, we're going to talk about the Tomahawk trial, but the Tomahawk registry actually put together a whole series of people, 714 patients with out-of-hospital cardiac arrest admitted to the ICU. So again, that's a selected group of people that made it. 31% had STEMI, and then 69% had other. And I'm going to talk about that again, because it's not just yes or no. If you really look at it, a third clear-cut ST elevation, a third clear-cut no ST elevation, and a third are post-arrest EKGs that I would challenge you to tell me, is that really ST elevation or not? And wide complex, atrial fibrillation, makes it very difficult to read the EKG. But in the patients that you looked on the right with no ST elevation, 58% had a significant lesion, 31% got PCI, 42% did not. So we're going to concentrate now on that group of people. The pros and cons of taking, you get called at 2 o'clock in the morning, out-of-hospital cardiac arrest, no ST elevation, right? Do you go to the cath lab or not? Everyone in this room has been called about that. So the pro was you could prevent injury and hemodynamic deterioration, and maybe they need to go to the cath lab for that to make them stable. But the trials did without cardiogenic shock. And in the con was delay in diagnosis. You're not sure if that patient's going to wake up, renal insufficiency, all those kinds of things that we know of. So the first trial that's really important was COACT. And this is a trial where they took 552 patients out of hospital arrest with no ST elevation, randomized to immediate angiography or not. Then they went to the ICU, and they looked at 90-day survival. Exclusion were STEMI, hemodynamic instability, so no cardiogenic shock, refractory arrhythmias, a non-cardiac coronary part of the arrest, okay? No significant difference, and about a 65% survival. So no significant difference. And then I'm going to show you Tomahawk, it's the same. So the bottom line is, if you don't have ST elevation and you don't have cardiogenic shock, you don't need to go to the cath lab. There's no benefit. Delayed angiography is fine. One of the only things significant was the time to target temperature was delayed in those patients. No differences in CKMB. So number one, congratulations, we actually have a randomized trial. So that's really important and a controversial question. I think it really made a big difference for us. Challenging trial design, but in the Netherlands, only 2% of people turned down consent. And it was the first randomized trial, and there's more on the way. So this concept of ST elevation or non-ST elevation, it's not quite that simple. It's not really binary as what we just talked about. And so you have to also remember the EKG is dynamic. So another important point is the mortality trial got criticized because it was mortality lower than expected. Is it? Not really, because I think people forget about cardiogenic shock, cardiac arrest interactions, and it's consistent with our registry data. So this is data from our STEMI registry, 6,000 patients. And if you had, over on the left, you have a cardiac arrest only without cardiogenic shock, your inpatient mortality is only 20%. Likewise, if you have cardiogenic shock alone without cardiac arrest, it's 26%. But together, it's about 50. All right, then we obviously take that into account in the shock classification, which we showed you before. And obviously, arrest, and you see it at every level of SCAI shock, having cardiac arrest markedly increases your mortality. So another really important point. And one of the things is, usually out-of-hospital cardiac arrest is a very heterogeneous population. But this wasn't, because they excluded those. So this is a pure group. No cardiogenic shock, no ST elevation, stay in bed. You don't need to take those people at 2 o'clock in the morning. And then the next thing is, what did they have? So they still CAF'd a lot of the people that went to the cath lab later, and about 65% had coronary disease, but less than 15% had unstable lesions. About 35% of people had CTOs, and the number of people that got revascularized was so small in both groups. But if they need it, if they recover neurologically, you can do it later. So the next was, whoops, back one. The Tomahawk trial, identical, almost 300 patients in both groups, identical results. So now we have I think this is settled from my perspective. So what about hypothermia? I'm not going to spend a ton of time on it because I think it's super controversial. But what the background is this has been around for 450 BC that shows that hypothermia actually can prevent both myocardial injury and prevent neurologic damage. And there were 2 trials in 2002 in the New England Journal that both showed their improvement, and these are the outcomes. But look at how small they were, 130 in each group in HACA and 40 in each group in the Bernard trial. But there were statistically significant improvements with hypothermia. And that's why it made it into the guidelines that you should do hypothermia. But now it's become very controversial. And this is a paper in the New England Journal last year, 1,800 people that were comatose after out-of-hospital cardiac arrest. Death from any cause, 50% for 48%, not different. And what they did is they cooled them either to under 37 degrees or to 32. But both groups got cooled. People forget that. So whether you're just preventing fever, and no difference in the Rankin score, and there was actually a little more arrhythmias in the hypothermia. So this is kind of a stake about hypothermia, raises questions, should we do it? And this is the outcome, and on the left is the temperature, and on the right is the no significant difference at all. So it raises a question about it. Certainly you don't need to go to 32 degrees. And I love this. I thought this was a figure of speech. When you live in Minnesota, this is a really important thing. Now, last, I'm going to end with just 30 seconds on what about patients with no ROSC? So this is a patient who you're going to stop CPR. Well, the Dimitris Yiannopoulos had done a trial at the University of Minnesota where they actually randomized those people. This was a pilot with ECMO. And they had about a 50% survival versus almost, if you stop CPR, they're going to die, right? These are patients who are really, we would call them dead. And they did a trial called the ARREST trial, published in Lancet last year, randomized to keep doing CPR, go to the cath lab with ECMO, or get it in the field. And they had about a 45% survival versus stop CPR, 100% mortality. This is not for the faint of heart. This is not simple, and it's a very difficult thing you need to think about as a community, but you have 45% survival. So it's something to think about. So you got to be very careful. You don't know where you're going because you might not get there. And I think it's really important with cardiac arrest and cardiogenic shock that you have standardized ways you approach this and you keep track of your data. Thanks.
Great talk, great talk. There we go. So I think that the literature has really helped here because I think we all get these questions at night. I think it's very helpful now with the EKG. If it's not ST elevation, then we know that we may not be doing any benefit, or maybe the benefit is outweighed by the harm. I have a question. We'll go back down this way, which is, talk about cardiac arrest, return of spontaneous circulation, and then you have an EKG. And we talk about the ones on the other extreme that continue to have arrest. Should you do ECMO, or should you just bring them to the cath lab? What about the patient who has been arresting for a long time? That's the one that I always have a problem with. They've been arresting multiple rounds of CPR for 30 minutes. And I guess these are the patients that we probably should have done ECMO, but it's at 3 a.m. Maybe they can't do it in the ER that quickly. And now they finally get circulation. What do you do with these patients?
Yeah, those are always the big challenge, right? So I think the two big things that we sort of think about are, if it's a young person, we actually had one of these just before I came. So he was a 47-year-old guy, and I think in that moment, no matter how long somebody has been arresting, I think we end up sort of biasing ourselves towards giving that person more of a shot. But I think it really comes down to, if they've been arresting for a long enough period of time where you think there's no neurologic function, then those patients often, maybe we're being too aggressive. At our institution, we end up still putting them onto ECMO and going the whole 9 yards. But we also find that those are the patients where those efforts are futile, as opposed to, you know, the lady I just did before coming, who came in arrested at the hairdresser, came in, got CPR the whole way, had return of circulation, got ECMO in the ED, came up, I opened her right for her ST elevations, and then she just walked out of the hospital 9 days later. So I think it really comes down to trying to understand how futile it is, but for now we go the 9 yards, and I think we need to know more. It's hard to know.
Yeah, I agree with those. I think it's important. For me, age is just a number. It just depends on how their comorbidities. You could have a 50-year-old who's so sick that you may not want to do your efforts and make it futile. But I think it's really important to look at the comorbidities. 2 is, did they have ST elevations or not, to be taken to the lab or not? And 3, family, really what the patient's wishes were, because sometimes we do all this and later we find out patient never wanted anything, never wanted to be on support. So I think those are really important, and if we determine that, it's okay to move forward, I think, if they were didn't have too many comorbidities, I think we would do the ECMO.
So I think your question is there a time when you stop and you say we're done? And I don't know the answer to that question. We have arbitrarily put a 60-minute window from the time of arrest to when their time on ECMO. To be very honest with you, I don't have an answer for you as to what the right number is. Obviously, I think the answer is always less is better. The quicker you get them on support, the better it's going to be, and the better outcomes are going to be in general. But we've come up with that number, and I think the systems of care required to get to that number are, I think, where I think the issue with most institutions are going to be. Most institutions, if you need to put them on ECMO, still need to have a perfusionist and still need to have a surgeon and all that stuff to be activated. And surgeons and perfusionists don't activate like cath lab teams do for STEMIs. They don't have, at least, and I'll tell you in my own institution, they have a 60-minute window to activate perfusion and surgeons for surgical emergencies. In the cath lab, obviously, we have 30-minute windows to do that. So we've come up with ways, strategies to mitigate that, and I'm sure Barbara can speak to this a little better, but I think that's going to be the crux of it. And the technical expertise to be able to put ECMO in the ER is a whole nother conversation that you need to have. Because to Barbara's point, what he said earlier, you can crash people on ECMO, but if you perf their RA or if you destroy their iliacs, you're never bringing them back, no matter what you try to do. So it's the process, the techniques are just as important. And the last thing I'll say is, when you're putting someone on ECMO who's fully in cardiac arrest and never comes back, you have to start thinking about the sequela of ECMO with no moving heart. Thrombosis of the heart, thrombosis of the ascending aorta. There are a myriad of other things that you can't just sit on, and these things can happen within 30 minutes of putting them on ECMO. So there's a myriad of different things that have to be thought about in those patients, which are beyond the expertise, I think, of most places and the experience in most places.
Well, and this is all about EMS and out-of-hospital care. I mean, it comes down to, sites like Seattle, Minneapolis, where you have this advanced network of care, while me and Cal are in the top 10 worst city in the United States with out-of-hospital cardiac arrest, where we just are so happy that we moved from last place to 7th to last place, where, really that thought of putting someone who's already arrested for half an hour is really almost at least double that time, where, it's really not applicable. But Tim, what do you think about, with the arrest trial and with all of this new information, is that the way that this field is headed?
Yeah, so I bring it up because number one, cardiogenic shock field gets criticized for not having randomized trial. And I think in cardiac arrest, I just showed you 3 outstanding randomized trials, right? And so then people can't look at you and say, well, you didn't try it. Now, Demetrius's trial, he deserves tremendous credit for this. I will tell you, it's important. This is a community decision, I think. And it's not for the faint of heart. So 50% survive, 45. That means 50% died. And all of us in the cath lab knows that at 2 o'clock in the morning, you bring someone in, put ECMO, and take them to cath lab, and that patient dies right on your table. That's not a pleasant thing. It's not pleasant for your cath lab. It's not pleasant how you deal with the, there's just a million complicated things involved in that. So it's not for the faint of heart. Second of all, it's really important to know that the communities that have done it do it very selectively. It's not end-stage renal disease. Usually there's a cutoff at 70 or 75. There is a 30 minutes was when the decision was made. No return of spontaneous circulation at 30 minutes. And then there was a cutoff there were a couple other cutoffs of doing it or not. So who were these patients? These were the 45-year-old with a large anterior infarct. This is the 38-year-old woman postpartum with a big pulmonary emboli. It's not just STEMI. It's a group of people like that. And when you look at the survivors, remember, these are dead people because you're going to stop CPR. And half of them lived. So I think it's something that communities can do it. Certainly in Minneapolis, the people that it's been successful. But it's not for the faint of heart. But it challenges us to, yes, you can randomize people. And yes, there's another horizon of where we can go if we can get it better. Can I ask one question before we go to the next talk? How many in here with their out-of-hospital cardiac arrest are still doing cooling? Raise your hands, yes. How many have stopped cooling? It's interesting. So I think, this is an area that I really don't know the answers for, and I wanted to show the data. Actually, there's a slide that I didn't put in after that, or that didn't show back. Actually, there was a study in JAMA Cardiology that they did cooling with cardiogenic shock that actually showed benefit. So I think it's still a topic that we need to think about and talk about. So, all right.
Well, we have some time.
Yeah, we do. But I want to do something fun here. So Allison's not here, but the topic is when and how to use hemodynamic support in shock. So what I'm going to do is I'm going to go down the line. I'm going to start with Bobber, and I'm going to give you each a case, and I'm going to ask you what support you would use in that patient. And then I'm going to ask the audience to vote yes or no. Do you agree with them or not? And so the first case is, this would be a Sky Shock B. So this is an anterior infarct, a 65-year-old. Blood pressure is 90. EDP is 18. You finish the PCI, and there's TIMI 2 to 3 flow. But they've been stable, and they're not having chest pain. ST segments are 50% improved. Do you use any kind of support or not? And why?
You said LV EDP is 18?
18.
Yeah, so I mean, I think there's a lot more nuance to that. I'm sorry. So I'm going to get a little bit more information. It depends a little bit on the age of the patient, why I got no reflow or why I'm not getting TIMI-3 flow. If I think it's just a microvascular issue, if it was late presenting, probably at least do a minimum of a right heart cath. But I would say that the role of a balloon pump here is not out of the question. And the reason for that is a couple of things. One is that at least hypothesis generating part of CRISP AMI was that it actually reduced the risk of hemodynamic compromise in the terms of advancement of heart failure. And so I think that there's at least some data to support that. The other thing that people forget about before or at least my era, was that balloon pump was actually shown to be effective in patients post-thrombolysis who didn't achieve TIMI-3 flow. So I'm a really big proponent and advocate of trying to be able to get TIMI-3 flow, and if I'm not able to do that in select patients, perhaps a balloon pump could be used there, but that's my thought.
All right, so that's great. So that's now the audience is going to say, so how many would put a balloon pump in that patient? And how many would not put a balloon patient in that patient? Okay. How many would do more than a balloon pump? Okay. So that's good. So mostly, and I agree with you. I think that is a potential indication for it. So that's SkyShock B, and I think it's a potential indication for balloon pump. All right, Pervez, next case. This is a classic Class C, so that you're going to hear. Cardiogenic shock. Patient, the pressure is 90 on norepi, the wedge is 27, the lactate is 4, and you're in the KF lab now, and you has complex multivessel disease, but you fix the thing. What are you going to do with that patient?
So I think in a case like that, where you have an elevated LV and diastolic pressure, you have them on pressors, and you didn't give me the index, but I'm assuming the index is going to be a little low in that case with multivessel disease. The first thing that I would pull out of my belt would probably be an Impella, if they can vascularly support the device. And then once you put it in, reassess the hemodynamics. And then based on that reassessment of the hemodynamics, determine what the next step would be. I don't think personally fixing the coronaries, until it's an occluded vessel, is of utmost importance. If it's an occluded LAD, yeah, you open it up and you fix it. But if it's not occluded, then you can, and if they have TIMI-3 flow down the vessel, you can sit, wait, reassess the hemodynamics, and determine first the hemodynamic support, and then determine the PCI strategy after that.
So you put the Impella in, and then there's multivessel disease, and you thought the LAD was a culprit. You fixed that. Would you do it in the non-culprit vessels now or not?
So probably not, especially if it's a CTO, definitely not. And I think, as long as you fix the culprit vessel, for now you can sit tight. There are probably case scenarios in which you may need to fix the non-culprit vessels, but those are probably rare and few and far between. Okay, and if you tell me, if you don't think it's really a Class C, or you don't think I'm giving you the wrong class, you can. So that's a vote for Pervez. That's a case for the Impella. How many in here would put an Impella in this patient? Okay. How many would put in a balloon pump? So passive balloon pump, I see no hands. How many would do more than and consider ECMO? And part of this is institutional, what's available and stuff too. So this is, that was a pretty standard thing so far. Go ahead.
Yeah, I'm surprised, right? So I don't know, maybe we're selecting the people who are already coming to meetings, and it's such a dichotomy, right? So 100% Impella, I don't believe it. So I'm going to say I don't believe it, and I'm going to say that I think a lot of people will still do balloon pump, and I think that's not unreasonable as long as you repeat the lactate in an hour very quickly. Why? Because you just do revascularization. You don't know which way this patient's going. They may get better. If they get better, it's okay to use something less as long as you're willing to upgrade quickly, and the beauty of a balloon pump is you can upgrade quickly. We've been doing more lactates in the lab, and if we're worried, we wait an hour or half an hour in the lab, repeat the lactate. Where is it going? Is it getting better? You're good. It's not getting better? Or are they having some instability or VT or something else? Upgrade while you're there. The key is not to leave the lab until you're comfortable that you don't have to come back to the lab an hour later. So that's what I'd say.
So I agree with you, Hari, not to leave the lab without a decision. But you do have randomized control trial data that essentially shows you that in stage C shock, that's an acute presentation that a balloon pump is ineffective at being able to change the clinical outcome of this patient. And I think if we're going to be purist about, wanting randomized control trials and working hard to be able to do this and get ethic protocols community by community, because that's the only way we're going to do it in the United States, then we have to actually take those results and use them. So I think it's wrong to use a balloon pump in this setting.
Yeah, I think the challenge, I think you're right for randomized trial, but the problem is all those trials were a mixed bucket. And so I think we still need to figure out, as you stratify by stages, where it might benefit and where it might not. It may be futile, certainly, as you get further up past C to D and E for sure. So I think I agree with you. I think the truth is somewhere in the middle.
All right, I purposely made it a pressure of 90 versus a pressure of 70, because I think at pressure of 70, it's an easier answer. And I think the other point is if you're in a community hospital that doesn't have an Impella, putting a balloon pump in that patient and transferring him is a fair answer. And the point about this is that these are not definitive answers to this topic. So Poonam, you're next. This is a Class D patient. He's on 3 pressures already. When he gets to the lab, you have a lactate. The lactate is 8, and the patient had he looks bad, and he had a out-of-hospital cardiac arrest and is non-responsive. Pressure is 60.
Did he have ST elevation? He's got 5 kids. So this is Class D. Literally, he's, I think, drowning at 3 pressures. So I think I would start off, we have to get some numbers quickly, but I think I would start with an Impella first. Quickly reassess in probably 30 minutes or so, and then see which way this patient's going, and then even up, if the CPO is less than 0.6 even after the Impella, then kind of go to the ECMO, or if PAPI is less than 1, then we know he needs right heart support, and then decide whether or not needs a cath based on the ST elevations, whether they were present or not. So I think that's the direction I would take.
So put in an Impella, revascularize. Would you do hypothermia?
I'm plus or minus. It's with the data we have right now, I think we could go either ways, but we are doing it. So.
All right, so audience, for that, your answer is Impella and see how they do. How many agree with that plan? Really important point, and I think the key thing we would all feel about that is a right heart cath is indicated in all. I'm trying to get at least simple cases so we can get through it, but you would have a right heart and lactates on all these people and blood gas for sure. So how many would do ECMO in this patient? Depend on the right heart. That's a fair answer. Okay, last one. This is a patient who's still having ongoing CPR. Mega, your case, ongoing CPR, good CPR has been in the lab, and gets there and actually is on a Lucas device and is unresponsive. How do you handle that patient? I think you told us already.
Yeah, I would go to ECMO in that situation. ECMO and an Impella for venting, and then start shooting the coronaries through single access through the Impella. Yeah,
that's another complicated question. I think, so this is the stage E, ongoing arrest in the extremist person. And I think that, how many people would do ECMO in that patient? Raise their hands. How many people would just stop and not go to the cath lab?
How old is that patient?
Well,
How old is that patient?
How old is he? Oh, that patient's 65. All right, so hopefully that was fun. The point of that talk that Allison was going to give was picking the right mechanical circulatory support. And I think it's nuanced right now. And I think it's also important that everybody realize the amount of actually randomized data that we have is limited. There is several ongoing randomized trials, the DANGER trial, which will be kind of Class C and Class D patients. There's 2 ECMO trials, which are going to be one in Class CD and one in more DE that are ongoing and should be done in the next year. Yeah.
Tim, can I just make one point, is that we're so dichotomous in our decision making right now. So if you have shock in Chicago, you're going to get a surgeon who puts in ECMO, and you're going to most likely get CABG. And if you have shock in Detroit, outside of Henry Ford, you're going to get an Impella, and maybe you'll be able to find a center that gives you ECMO, and you're going to get PCI. And it's really, really interesting to me as we travel around how the institutional practices between interventional cardiology and surgery really really make the decision on these advanced D and E shock patients.
All right, perfect. So we're going to go. The next one is Alaswad is going to talk to us about complications of hemodynamic support, prevention and treatment, which is why this is a really important decision, because the complications rate are not zero.
Thank you so much for inviting me to give this talk. So you decided to put a mechanical circulatory support device. My slides, please. Perfect. So mechanical circulatory support devices, for mysterious reason, in the clinical trials do not have complication. In real life, they have a lot more complications. And the most important, how to deal with these complications. So when I start kind of thinking about this talk, and I'm trying to kind of count in my mind all the mechanical circulatory support complications I've seen, and I figure out I need an hour and a half to talk to you about them. So I cannot try to cut it down as fast as possible. So you have to keep in mind that the patient who need mechanical circulatory support are the least tolerant for any mechanical circulatory support complications. And these are some of the complications, like how I divide them in my head: cardiac complications, stroke, which is neuro complication, sepsis, and access complication, and there are other things. So I'm going to go over a few of this really fast. And this is one of our patients here. And if you notice, the Impella kind of digging into the ventricle. I have not seen that myself, complication going through the apex of the ventricle, but I've heard about it and I've seen pictures of it. So you have to pay attention when you do that. I think one of the most important complications is our half knowledge about mechanical circulatory support. And a lot of us put a mechanical circulatory support and send the patient to the CICU and go home. And the patient will, the device will suction all night long, and they will forget about the right ventricular failure. So I think other ventricular failure, when you use mechanical circulatory support, if you don't pay attention to that, this is a major complication, and it will kill the patient. Other complication could be really mechanical. This is a needle sticking into the heart from the right atria to the left atria. You could actually stick the stitch complication. You can have so many other, you can perforate the aorta. So how to prevent this? We use, at Henry Ford, we use TEE or ICE guided, and you always verify your wire. Every mechanical circulatory support device has some complications, so you really have to be well versed in them, and you have to follow the protocols. But more importantly, you have to have early recognition. Most of the mechanical complications that are caused by mechanical circulatory support to the heart actually lead to the demise of the patient. We all know that stroke is a major thing in mechanical circulatory support. Even balloon pump is associated with mechanical circulatory support. You save the patient, everybody high-fiving themselves in the cath lab, and the patient goes up intubated to the CICU. The worst thing it could happen, because nobody will pay attention to the patient level of consciousness if the patient had a stroke. Now, how to prevent that? Honestly, I don't know. Now, there are several studies. We use PTT, we use ACT, we use anti-factor 10 level in how to monitor this anticoagulation. Really, the jury is still out. There are correlation between the PTT and the factor 10 level. So many other factors could play a role in the response of the patient for anticoagulation. However, the stroke complication is not only related to anticoagulation, so there are retrograde flow from the groin. So I think patient selection and device selection is very, very, very important. Of course, Patients with a cardiogenic shock are in inflammatory state and also actually have immunodeficiency state. They are not responding really well, and their guards are down against bacteria. So you need really to have meticulous technique in your cath lab. You can't be without a mask and a hat and gloves. And you need to early detection of these complications. And how to treat them, you really need to the balloon pump, you need to switch it, remove it. Devices, it need to be come out as soon as possible if the patient develops sepsis. These all what I know about these other complications, but these are, I'm very well versed with access site complications because that's the most common complications in the world of mechanical circulatory support. The most important thing is to have really meticulous access technique. You cannot really just stick a needle in the SFA or the profundus or a high stick and then put a 14-French sheath in a high stick and expect the patient to survive. You really have to take your time, and we use both fluoroscopy and ultrasound guidance. And after you got the stick, you really should get an angiogram of the vessel, because you're not only deciding which mechanical circulatory support and the tolerance of the patient for, you also planning your complication management. So I need to make sure that I'm away from the profundus. So when I remove the device, if I need to put a covered stent, I need to make sure that I'm not going to close the profundus artery when I put a covered stent. Similar when you do axillary artery access. And mechanical and access complication are the Achilles heel of mechanical circulatory support. The 14% in the best numbers. The clinical trial shows less numbers, but I don't actually believe it because the sterile environment of the clinical trials is not the real life. So other complication is, and the most important, is ischemic extremity. This is exceedingly important. You save the patient life, but they lose the limb, they lose the leg. Most of the time, the patient family will tell you he does not want to live, he or she does not want to live without a limb. Or if it's a young mother of 4, now she loses her limb, a leg, and she's going to be disabled for the rest of her life. So the patient should, sorry, miss typo here, should never leave the cath lab before you ensure really good perfusion in the leg, or the arm to that matter if you go from the extremity. It's very important when they send them to the ICU that have early surveillance about ischemic extremity. And in those continuous flow, when you look in the left here, the patient has actually sheath and has antegrade perfusion or retrograde perfusion of the limb. This is non-pulsatile, so you need to train your nurses and train your fellows and train everybody how to detect ischemia, because they might not feel a pulse and they're gonna call you in the middle of the night. They need to call you, but like they might call you unnecessarily. And if all that failed, you actually could provide alternative access. Transcaval access is surprisingly very easy and surprisingly very safe. And believe me, this is still kind of people cringe when I show them this picture, but it's not all that cracked up to be. Anybody can learn it and everybody can do it. We have a large series now of patients. We use a transcaval access in young patients who came with postpartum or myocarditis, cardiac shock, and they did really good. No arterial access other than the 6 French that required to perform this access. Now, vessel dissection and vessel occlusion, there are treatment. We can treat this in the cath lab. The good thing about extremity, you always can go retrograde. So if you dissected the common femoral artery in the left or the brachial artery here, you can go from the radial or go from the popliteal, and that will actually get you in the real axis. I use self-expanding stent. You can use IVUS in the periphery, and they're always, the surgeons are very willing to take these patients. However, I warn you, those patients are very sick, and arterial clamping and vascular surgery is really, really high risk in those patients. So if you can't treat them in the cath lab, please do it. Large sheath might be full of thrombus. This is one of our patients. Actually, Baba reminded me of this patient. I put actually this transcaval access, and that's a 5-0 impella. And when we removed it, that squeegees the clot in there. So distal embolization upon device decannulation is, I think it's 100% of the time happens, but sometimes we don't recognize it. So the problem, you cannot use TPA. Thrombectomy is really less effective. Surgery might be the only option. Prevention is more important. Assume high risk of embolization anytime. You can actually prevent embolization to the lower extremity by putting a cuff pressure or occlusive balloon, and that will be able to treat. So, sorry about that. I need to come back here. Bleeding of access, this is one of the most recent patients. There is about 2 liters of blood in that thigh, and the reason is the cannula. If you notice, the cannula in the right goes in, and when the patient goes to the ICU, slides back, and the patient bleeds around it. The other cannula, the right and the left to it, has actually a collar that prevents it from going in and is safer. You need to learn how to do a balloon tamponade and use covered stent. These are some of the device-specific complications. ECMO, north-south syndrome, you need to know how to treat that. You can add a cannula, arterial cannula, arterial blood or outflow cannula in the right side, and LV venting, impella, papillary muscle interference, reposition and prevention is better. Now I'll show you the picture later how I prevent that. Tandem heart, you need really to train on transeptal and imaging guidance, balloon pump, gas embolization. If that happens, I cannot help you there. I don't know how to treat it. So hemolysis with impella happen because so many reasons. Impella position in the subvalvular. This is how I cross the valve when I do impella. I don't cross the valve with the wire because I knuckle actually the pigtail in the ventricle, and I keep the wire in the apex of the ventricle. This is not going to go in the subvalvular apparatus. Impella outflow in the aortic valve, you need to reposition, and sometimes a patient have low volume. In summary, mechanical circulatory device have increased complication. You need to be ready for them. Patient selection is exceedingly important. Avoid unnecessary complications. Device and access site selection is next in importance. Meticulous technique is really, really important in these. And this is Detroit. Please come there.
That was fantastic. And I think the key point of this session is that's why the decision for or not for mechanical circulatory is so important, because there are complications.
Absolutely.
And you have to know how to manage it. In the interest of time, because we want to stay on time, we're going to finish with a case. And so Mike Megley, are you there? Are you out here, Mike? So Mike's going to finish with a case, and we'll have 10 minutes to discuss the case.
Well, thank you. It's a pleasure to be here, and an honor, actually. So it's humbling to follow all these great talks, but consider this a little break before the break then. So my case, RV marginal loss, not a big deal. How many times have we heard that? So no disclosures. So patient is 49-year-old man, ischemic cardiomyopathy of 35%. He had an LAD PCI like 4 weeks before, and he came for RCA, CTO, PCI. So quickly, these are his images, some ambiguous cap, long CTO. Going forward, we just plan to go integrate or either retrograde. Integrate wire didn't work, so we just cross retrograde through septals, and then we just knuckled and did reverse cart, and this was the final result. And we were pretty happy, high fives. Patient goes to recovery, and then we move on to the next case. Before we load the next patient on the table, 30 minutes into recovery room, patient has VFib arrest. 4 rounds of ACLS, ROSC, and then the patient is rushed back to the cath lab. And this is the picture on the left is his first picture we got, and on the right, this was the final picture of the angiogram. And what we see here is the only thing that's different is the loss of this very small RV marginal that I'm sure that a lot of people would say that's not a big deal if we lose it. So this led to ACL, to the cardiac arrest, and now we have this patient, blood pressure kept going down, and then we take another picture, and this happened. Now we're in the MAP 40s, and we're in the cath lab, everything is like haywire. We just quickly wire and balloon this to restore flow, start pressors, and now RCA has STIMI-3 flow, patient on pressors, blood pressure going down, intubated with a set of 90%, and lactate came back as 7. And next step here, forward, we practice what we preach. And this patient was like actively was crashing. Once we get him stabilized, we get a right heart cath. And these were his numbers. Blood pressure now is 100/80 of multiple pressors. RA pressure is 21, wedge is 25. PA pressure, as you see, PAPI is 0.61 and index of 1.5. And I would urge you to, and I mean, I'll ask the panel first and everyone, what device would you use now before we move into the next step? And all these devices we can put very quickly. So, what do you think?
Yeah, I can start here. So, great case. I think I'd start with an Impella. The PAPI here is 1, which is low. I think we lost the marginal, but this is again a case that I would put an Impella in, redo the hemodynamics, and then decide on an RP Impella if we needed. That makes the most sense to me.
I agree. I'd do the same.
Yeah, it looks like he needs right RV support, at least what it's seeing right now. The wedge is 25 too, which is concerning, but I think he definitely needs some RV support. No questions asked about that.
So you're saying right heart support? Is that what you're saying?
Start with right heart or start with left heart?
Yeah.
Okay, so which device would you pick for right heart?
Easiest one to put in, probably RP Impella.
Okay.
Fix the marginal.
Okay, that's a great idea, and that's what we thought we will do, but we wanted to get him stabilized on multiple pressors. We didn't want him to go back to, arrest, and we want to stabilize this. And here's the rationale for what we did, and actually the rest of the case is very interesting. We thought that with all this crashing, we were sure that RV marginal was the culprit, but and definitely RV was the main reason of this shock. So we first opted not to do an Impella, but because we have a man, he already had ROSC, and we've classified him with E, we decided to go ahead and put ECMO in. So we went and put ECMO in place to stabilize all that, and then we wired the RV marginal, we did final ballooning and a final kissing, and this was our final result here. So just on ECMO, we got the RV marginal fixed and sent him up. And actually, the important part about this case is actually the intense follow-up to next day. So next day, patient remains on pressors, on ECMO. He was not getting better. Lactate kept going up. RA pressure is 5, of course, we're pulling blood out of the RA. We could not obtain wedge. So at this point, we actually were thinking out of the box, and what do you think of the next step? I mean, the patient is fully on ECMO. I know I'm missing a lot of numbers, but these are the numbers I have right now. So what do you think the next step should be? Sorry? Okay, that's a great idea. Does everyone agree?
You also want to make sure you're not having a lactate from some other reason, Garvin syndrome or ischemic gut. These are things that don't clear despite low perfusions.
Right, or abdominal ischemia.
No. So, yeah, go on, Suma.
No, he's an
he's
ECMO.
an ECMO.
Remember, so the
He's an
ECMO is actually with RA drainage. So
Yeah, he's an ECMO. So that's actually, the RA is very expected. So the way we thought about it is we probably with the RV, the main culprit of this is the RV infarction. We placed an ECMO and we placed a lot of afterload on that heart. And remember, his EF is 35% anyway. Even if the LV didn't take any hit, still it's very tough on it. So what we decided to do actually is that we decided to de-escalate from the ECMO. We placed the Protect-Ju, but during the process escalation, we also wanted to place an Impella CP. So we can't use 3 devices on this patient, but interestingly, lactate improved significantly next day. The patient was decannulated 3 days later, and he was discharged home 2 weeks later. We saw him actually in clinic after. He was doing really well. So in conclusion, I'd say, first of all, RV marginal loss might not be an entirely benign event. I'm now very paranoid about marginals. And in shock, quick action is necessary. I mean, we stabilize them and we try to do the right decision and, of course, open the marginal. Choice of devices, maybe we thought should be according to the pathology, and the pathology here is clearly the RV, but we wanted to give him full support, especially in EF 35%. And the clues monitoring for de-escalation. You gotta be ready to change plans for escalation or de-escalation. This snapshots from the recent AHA paper that would make you consider escalation. And as you see, like all these things, we should have a very close eye on. Thank you.
You know, so it's a really good case, and it just shows how complex this could be. Another thing I'd say is that, so you had the arrest, a patient did well, you had the arrest, and then you came back and you see that the RV marginal potentially ischemic, but then you had stent thrombosis too. And so I think this is clearly a point where you got to make sure that you have adequate antiplatelet, and I think Cangalore in this case would have been absolutely essential, right? Not sure.
Absolutely. So can you, and the way we did it in the cath lab, as Harry suggested, like we always wait. So we did it in a stepwise, and I can't remember the details yet, but I think we did the right ventricular support. We thought the primary hemodynamic problem is going to be right ventricle, but we want to vent. So we did a right ventricular support, and then with more hemodynamic studies, we discovered we need to put an Impella, and he actually did better than ECMO. So his blood pressure went down. Obviously, his platelets are not well inhibited with Plavix, and he developed stent thrombosis. So antiplatelet therapy is very, very important.
All right, everybody, we're going to finish on time, Manos. This was a fantastic session. I really want to thank our panel and the speakers. Really tremendous, and thanks to you for being here.